So, dear chairs, ladies and gentlemen, respected colleagues. First of all, before I start my presentation, I would like to express my really gratitude to organizer of this wonderful meeting for a kind invitation, especially to my dear friend Rosen Major, who invited me and gave me excellent opportunity to be for first time in my life in Russia. I spent several winter holidays here in this wonderful country, in Bulgaria, with wonderful ski resorts, but never been here. So once again, Rosen, thank you for your kind invitation. In the next 50 minutes, I'm going to talk about the complication, or let's say functional outcome after resection of the rectum or low rectal resection. Is there any impact of the LARS in, let's say, paradigm shift of the treatment of the rectal cancer? It's my non-disclosure or conflict of interest. When we look back in the history, I think about 20th century, regarding the treatment of the rectal cancer, we can divide it in two periods. The first half with oncologically justified surgery, and the miles was first in the line. And as you can know, as you know, without his theory of perirectal lymphatic spread, recurrence rate will be still as high as 95%. Second half of the 20th century give us the sphincter saving procedure with the Claude Dixon from 1986. And especially after, let's say, cornerstone of treatment of the rectal cancer, it's a Bill Hill total mesorectal excision, 1982. He gave opportunity to reduce the recurrence rate below the 10%. But at the end of 20th century, we noticed that there is some happen with all these patients 1 year or 2 years after low rectal resection. And they started the story about the complication or functional outcome or LARS. So this question was asked 1996, so 30 years ago. Do the patient perceive any clinical benefits regarding the low rectal resection compared to the state with the rectal cancer? And if you look in evidence-based, Cochrane Library database, published 2012, they didn't find any robust evidence that quality of life after rectal resection is better than those who has permanent stoma after abdominal perineal resection or Hartmann procedure. So the case, is there always the patient with the stoma, definitely stoma, worse quality of life if you compare with the sphincter saving procedure, whatever of the level of the anastomosis, high, low, ultra low, and many other complications, many other options. So growing demand of better quality of life nowadays, less aesthetic impact, longer survival, give us the, let's say, change of approach of the treatment and think about a treatment of the rectal cancer, especially regarding the approach. So we are faced with so many minimal access approach, lab, robotic, and NERAS protocol. But we think about oncological outcome. We think about reduced local recurrence rate, disease-free survival, and increased overall survival. But also, we think about most important recent years, quality of life. Not only LARS, but also urology problems and sexual dysfunction. The definition of LARS. So, as you can see, the published 2009 in colorectal disease as disordered bowel function after rectal or colon resection leading to detriment of quality of life. 1 year later, there was international consensus about the complication and also published in colorectal disease. And they define LARS as at least one symptoms resulting at least one consequences. Basically, if you look in pathophysiology aspect of the LARS, definitely it is different level of resection of the rectum. So loose of rectal capacity as a reservoir function, and compromised reservoir function of the neorectum with different kind of the colon as a pouch, or maybe straight anastomosis, and maybe lateral to terminal anastomosis. But basically, we are faced with anal sphincter dysfunction, afferent sensory loss, especially in a case of preoperative radiotherapy, pelvic radiation disease, autonomic degeneration, and mostly of these low rectal or ultra low rectal anastomosis covered with a protective stoma, ileal, or colostomy. Do we have validate tools to, let's say, assess the extent of the LARS? Yes, we have. We have LARS questionnaire, and we have a memorial Sloan Kettering bowel function instruments. Basically, there are two the same validate tools, but LARS questionnaire is the most common in published literature due to simplex, due to easy to and accessible, and a low number of the questions. And if we analyze the LARS score classification, we can see that if we are up to 20 score, there is no LARS. 21, 29 light LARS, more than 30, it's a major LARS. But very important thing, when you assess the level or the type of the LARS, there are two dominant patterns. We have incontinent dominant LARS, which is the main risk factor is preoperative radiotherapy. And the other, we have the frequency dominant LARS, which main risk factor tumor location from the anal rouge. And from physical point of view, it's a more profound association with poor quality of life, this second one. How can we assess and how long it's necessary to follow this patient to make diagnosis that the LARS, the patient suffer from different kind of LARS? We need some duration of the follow-up. We need the short-term symptoms, let's say from 6 to 12 months, or long-term symptoms more than 12 months, maybe after 24 months, so 2 years after. And as you can see, these numbers is going more than 46, 49%. And I would like to show you briefly our results. We follow our patient operation during the 2024. So we performed 146 elective rectal resection. Among them, there was 50 with low anterior resection. So here is the set of questions we mailed or asked our patient over the phone after 6 or 12 months, and interpretation of our results based on regular basis of the LARS questionnaire. And we are faced with the results that only 24% of patients had no experience, any symptoms of LARS, but 75% had a major LARS and a minor LARS. And here is the set of the risk factor regarding the major LARS to our patient. For LAR protective stoma, anastomotic leak, and duration of protective stoma more than 12 months. And if you look in literature and compare the results, and I would like, this is the cornerstone of published paper regarding the LARS, what's going on after 14 years after preoperative short course radiotherapy plus total mesorectal excision in a case of Dutch TME trial. They concluded that 56% after 14 years experienced major LARS, versus 35 with those who is treated only with TME surgery. So TME is probably the main contributing factor with the LARS. And if you look and analyze plenty of literature, all this reported that the major LARS after more than 2 years, it's more than 40%. Even in some paper, there is up to 90%. So almost all patients had experienced different kind of LARS. So we have to be honestly to our patient in decision-making process when you plan to do some kind of rectal resection. You have to explain that you can expect after 1 year or 2 years leakage, toilet dependence, and many other things. And the question is there any difference between the approach, open, laparoscopic, or robotic? Up to now, there is no statistically significant difference. Why? Because we have to resect the rectum, whatever, with open, with a laparoscopic or robotic, to prevent and to cure the cancer. If you add urinary dysfunction, if you add sexually dysfunction, it's a really great problem for some patients. And this meta-analysis published in Asian Journal of Surgery conclude that the main risk factor for LARS, level of anastomosis from anal verge, level of the cancer from anal verge, radiotherapy, anastomotic leak, and diverting stomach. And this is the question, this is the survey among the surgeons, American Society of Colorectal Surgeons and Spanish Society participate in this survey. And they answer on 23-item questionnaire. But two, it's most important regarding the LARS. And they answered on this question, what is the onset of defecatory functional impairment, distance from the anal margin, anastomotic leak, and preoperative radiotherapy. On the second question, related to LARS, what is the suffering defecatory impairment after surgery for rectal cancer? They give the answer the same. So those three risk factors are the main predictors of LARS. How should we treat this? So first we need to assess. So is it minor? Is it no LARS, minor LARS, or maybe major LARS? And as you can see, this is the paper published last year. Minor LARS we can treat with conservative therapy, dietary modification, pharmacotherapy. Major LARS, first we need to assess, is the predominant component incontinence or frequency emptying? So if it's the predominant incontinence, biofeedback treatment is the first option. Predominant emptying difficulties, pelvic floor muscle training plus transanal irrigation, or mixed symptoms, combine those previous two approaches. In case of all these approaches fail, we have to do with, let's say, some sacral stimulation or SNS or percutaneous tibial nerve stimulation. Results is a little bit, so there is dilemmas about this. And in the end, or all these approaches fail, permanent end colostomy is the final solution. And the question, is it possible to avoid the LARS at any case? Yes, if we preserve the organ. How can we preserve this? Increase the population screening program, local excision, and non-operative watchful waiting approach. Yesterday, Bella Teleki, we talked about this. I will just briefly pass to the increase the population screening program, especially the last 10 years in the young people below 50s. We notice increase the number of young patients with a rectal cancer. And also local excision as a primary treatment. If we have diagnosis in early stage, in first stage, in A, we can do it with local excision, or even after chemoradiation. And in this particular case, in this study, show that after chemoradiation, with reduce or downstaging or downsizing of the tumor, local excision sometimes is good options. Already mentioned non-operative watchful waiting approach with cornerstone paper, Angelita Haber-Gamma 2004 in Annals of Surgery, give us opportunity not always to operate the rectal cancer, but what is the most important thing? To identify the subset of patients who can have the benefit from this preoperative radiotherapy, because the surgery must be associated with high morbidity rate, mortality rate, even and also functional problems. If we add total neoadjuvant therapy nowadays, we increase the number of we increase the number non-operative or clinical complete response. So what is the answer? Does the LARS change the treatment strategy for rectal cancer? Partly, yes, it does. But we need more evidence to define pathophysiological behind colonic motility, feedback mechanisms, compensatory factors would prove useful to eventually develop a novel technique to treat the LARS. So, dear friends, in the end, definitely high incidence of LARS symptom, even in specialized center from the rectal cancer, demonstrate that the functional structural alteration caused by rectum removal may be minimized, but not avoided. It's necessary, I think it's most important thing, to inform the patient in decision-making process for possibility of LARS in postoperative failure. It must be adopted treatment for lower symptoms as soon as they diagnosis. And we have to know the mechanisms of functional intestinal alteration. And also, it is multidisciplinary team job. surgeon, gastroenterologist, radiation oncologist, pelvic floor nurses, and the patient. Last but not least, I would like to inform you that, and also using this opportunity to invite you in our international colorectal meeting this May, 7th and 8th May, in Niš, in Serbia, and with a really high number of international, very well-known participate and faculties, and also for national experts, and just to save the data and be with us 7th and 8th May in Niš. Thank you for your attention.